Hello, everybody. As we approach the 1 year anniversary of COVID, I was asked to give a very brief update about what we've learned about pediatrics and COVID in the past year. So we're going to spend about 15 minutes going over just the highlights. Keep in mind, each one of these things that we discuss probably could be a lecture in and of itself. This is pretty much just the highlight reel. So let's start with the pediatric numbers. There is a website the American Academy of Pediatrics maintains that reports state level data about every 2 weeks or so. You can see that most children have mild disease. A fair number of children also are what we call asymptomatic carriers, meaning they're not showing any symptoms, but when we screen them for something else, they show up positive for COVID. So a good example of this that we've been having at Cooper is children who are going to the operating room for appendicitis get screened for COVID. And a number of these children who don't have any symptoms at all, except for the symptoms related to their appendicitis, have been coming up positive for COVID. The other trend that we saw that I'm sure everybody's aware of, we saw high increases after the holidays, both Thanksgiving and then Christmas and New Year's, of the increase in cases. Luckily, in the last 2 weeks, that increase has come down to about 4%. And we'll see what those numbers look like now that the weather is getting better and we are getting outside. Although the concern is, are we going to see a spike in young adults and older pediatric patients as we approach spring break? This is a screenshot of the AAP website. If you are going to be looking at this data, there's a couple of things that you need to know. Statewide, there is no unified definition of what a child is. So if you click on these states, you'll see some of them define a child as 14 and under, some of them define a child as 20 and under, and then there's a number of states that sort of define children in between those two subsets. Interestingly, as we look over a year, some states, as the year progressed, actually changed their cutoff of what they consider a child. So it's difficult to compare the data from early in the year to now because some of those states have actually changed their cutoff of what they considered a child to be. There has also, over the past year, been some changes in what they consider probable cases, definite cases. So those definitions have changed as well. So it makes it a little bit challenging to look at the data from the beginning of the year and compare it to the end of the year. Mostly we are just using this data sort of on a week by week basis to see if there's any particular trends. Then when we talk about pediatric COVID and who's at risk, early on, when we first started to see COVID, we assumed that the kids with respiratory problems were going to be the ones hardest hit. We assumed that the kids who were preemies and have bronchopulmonary dysplasia, or the children with asthma, we assumed that those kids were going to be the hardest hit. What we found out over the past year is that's actually not the case. We have seen kids with non-respiratory comorbidities, they hit a little bit harder. So these are the kids that have malignancy, that have cardiac disorders, endocrine disorders, in particular diabetes, some GI chronic issues like ulcerative colitis or Crohn's. Those kids are often immunosuppressed. And then hem-onc kids in particular are sicklers. When you look at the populations that are at risk, it's really our adolescents and young adults. Those are the kids that we've been seeing mostly get MIS-C and get very sick. We have not seen a lot of that in the younger kids, although it does exist. And then if you look at our population, Black, Latino, Hispanic, and Asian seem to be at increased risk. So why is it that kids are getting less COVID and getting less sick? We seem to think that kids have a number of protective mechanisms. They have been exposed to recurrent and concurrent infections, especially kids that have been in daycare school. The average 1-year-old who is in daycare that first year gets a number close to double digits of viral infections. So their immunity is in the best shape when they encounter disease. A lot of these kids have been exposed to other coronaviruses, so they have seen this before, although it's slightly different than COVID-19. The coronaviruses are similar in a number of aspects, so when they encounter it, they may not get as sick because they have seen variants of that virus before. They have higher levels of melatonin, which we think may be protective. They also have had a number of vaccines, especially live vaccines, that seem to provide some protection. Although it's not against the coronavirus in particular, it does ramp up their immunity and make them stronger when they fight other things off. And then they obviously had a lower intensity of exposure to COVID, especially early on when we were locked down and kids were not in school. They were not going anywhere, so their exposure was much less. Adults, on the other hand, they have basically a lot of inflammatory processes going on that seem to make their COVID worse at a baseline. They have a higher prevalence of comorbidities that can be associated with more severe disease. There are some studies looking that adults have higher density and increased affinity for the receptors that we see for COVID. They also have age-related changes in clotting and sort of endothelial damage that make them more susceptible. And adults seem to have lower levels of vitamin D in general. Vitamin D in some studies has shown to be somewhat protective against COVID, so having a decreased level is not protective. So we are not going to spend a ton of time on treatment. There is not a great volume of pediatric data on treatment. If you click on this QR code, it will take you to the CHOP pathway, which will bring up a nice table which divides disease into mild, moderate, severe, and critical, and kind of goes over the data, what little data there is for treatment in those particular subsets. As we progressed throughout the year, we started to see what was eventually labeled as MIS-C, multisystem inflammatory syndrome in children. Initially, when this came out in May of 2020, people were discussing how similar this looked to Kawasaki's, and initially, some of these kids were diagnosed with Kawasaki's disease. You can see from this slide, it looks very much like Kawasaki's. These kids have fever, they have conjunctivitis, they have rash, they have strawberry tongue, they have cracked, peeling lips. They can get redness and peeling of their extremities and sometimes their groin as well. When we talk about MIS-C, it's divided up into possible MIS-C and then suspected MIS-C with shock. This is the one that we worry about. These are the kids that have myocardial dysfunction, they're hypotensive, they require vasopressor support, and some of these kids have required ECMO. We have had a couple of kids at Cooper that have been very ill and have required ECMO support. So when we look at possible MIS-C, it's really a fever or a history of fever, 100.4 or higher for 3 days, and then they have to have at least 2 clinical or historical features, which we will discuss on the next couple of slides. Obviously, the suspected MIS-C with shock, they need to have signs or symptoms as possible MIS-C, but also need to have myocardial dysfunction or hypotension to go along with the other requirements. So these are the things that we have been seeing with MIS-C. Like I said, it resembles Kawasaki somewhat. Really, when you think about these kids, they have to have a history of COVID or a close contact with known positive COVID case in the past 4 to 6 weeks. So these kids, not all of them have had a positive COVID test. Keep in mind, early on when we first started seeing COVID, we were not testing children. They were not considered a high priority population because they were not getting sick. So for us in the emergency room, we were trying to save all of those tests for the adults that were critically ill. So we were sort of early on, when we weren't sure what the pandemic was going to do, rationing those tests. So there were a number of children that may not have a positive COVID test. There are also a number of children, like we said, that have mild disease or may have been asymptomatic carriers. So just because they didn't have a positive COVID test somewhere in time doesn't mean that they can't have MIS-C. You really have to spend some time going through the history and talking about illnesses or contacts and things like that to sort this out. So the clinical characteristics that we're looking for is rash. GI symptoms, extremity changes, the oral mucosal changes, conjunctivitis, lymphadenopathy, or neurologic symptoms. Keep in mind that they have to have 2 of these things plus fever and then a history of exposure of COVID or actual COVID in the past 4 to 6 weeks. So we are not going to talk about treating MIS-C. Again, I refer you back to that CHOP pathway. It is treated very much like Kawasaki's disease with steroids, IVIG, and other supportive measures, and then those kids are monitored over time. Interestingly, in the past year, we have seen this sort of pandemic inside of a pandemic. We have started to see more EVALI, which is e-cigarette or vaping product use associated lung injury. When you look at these kids, they present just like COVID. Their x-rays look just like COVID. They often have elevated screening markers like CRP, SED rate, etc., that we are seeing in the kids that have MIS-C. Really, the key to this is asking the kids history. So are they smoking? Are they vaping? What kind of things are they exposing themselves to? And often kids are not being very upfront about this. We don't find this out sometimes until after the fact when we really push them. Keep in mind, getting parents or caregivers or whoever is with this child outside of the room and asking that history is sometimes helpful. And then there's been a lot of discussion about COVID variants recently. We do not have a lot of information in pediatric patients. There's some data to show that the UK strain spreads up to 70% more easily. The South African strain, maybe 50% more easily. There's some discussion about whether or not the UK variant causes worse disease than previous strains. There's a lot of questions about Brazil, California, and South Africa variants, whether they cause more serious illness or increased risk of death. All of this, at least in pediatrics, remains to be seen. We're not really sure. If you do look at the data the past 2 or 3 months in the US, there's been an increase in the percentage of children diagnosed with COVID-19. There's a lot of discussion about whether or not this is related to the variants. We are not sure. Like I said, early on in the pandemic, we were not testing kids. So is this related to more testing? Is this related to the holidays that we had? Is this related to relaxed social distancing? We are not really sure at this point. We're just going to keep a close eye on things and see what pans out. Return to school has been a huge question on everybody's mind. Anybody that has kids or is around kids, you will often find yourself, if you're in the medical field, especially if you care for kids, people are asking you all kinds of questions. These are just an example of 2 studies. There's actually a number of studies out there that show that it's very safe to return to school with the appropriate precautions. So the AAP strongly feels that we should be getting kids back to school, not only for their education, but also for their mental health. When we look at the data, it is not returning to school that is getting us in trouble. It's the things outside of school. It's the wrestling that's going on after school. It's indoor basketball. It's social gatherings. It's people traveling for the holidays and gathering. It has not been a problem for kids to return to school with the appropriate precautions. It has been a problem to control those extracurricular activities. So if we want our kids to get back to school next year and back to normal, we really need to give some serious thought to what it is that we're doing outside of school. And then lots of discussion about the vaccine. For pediatrics, there is not a vaccine currently for pediatric patients. The closest thing we have is Pfizer is approved for 16 years and older. Moderna and J&J are 18 years and older. There are currently trials going on right now looking at kids down to age 12. We are hoping that that vaccine will be approved early this year, and we are hoping that there will be widespread distribution of that vaccine in the fall. There are plans for trials for younger children in the next few months. They are considering a lower dose for younger children, but that has yet to actually start. So we'll see what that looks like in the next couple of months. There is a lot of talk about vaccine hesitancy. There are some resources at the end of this presentation. There's one resource in particular where the pediatric infectious disease chief from DuPont, gave a great lecture where he goes point by point, talking about the concerns that people have about the vaccine and really how you should discuss that vaccine with other people when they ask you questions. So the other interesting thing about pandemic that we have seen is that our PEDS volume, both pre-hospitally and in the hospital, has taken a huge nosedive. It is starting to recover, but it has been very low for very, very many months. We have struggled with keeping our residents and our pre-hospital providers current on education, current on their skills, current with their comfort level of caring for pediatric patients. At Cooper, we are currently looking at an Oculus Quest platform that has some very basic PALS and PEDS assessments on it. It's exactly what you think it would be. So if you have a teenager at home that has an Oculus Quest, it is the same device. So a provider would put that on, start a scenario, and interact in that scenario. We are finding currently that this is very basic, and we are hoping that they can expand it and update it and make it a little more challenging. Two other things that we have recently been doing is, if you look at the asapsim.com website, there are a bunch of YouTube videos with PEDS cases. They are good basic videos covering basic topics like seizures, shock. They have pictures of kids, they have the monitor. This is basically a video that you're going to stop and start as you run through the scenario. They are great for people that maybe are a little uncomfortable with their PEDS knowledge, because they have attached teaching points and a very structured debrief with them. So this is something easily that you could pick up and do in a day with your providers. The website on the left, the virtual resuscitation room, is a little more complicated. They have both pre-made scenarios and directions on how to create your own scenario. This is really more of a remote, real-time, active resuscitation. So you would load your scenario, folks would log in via Google, and you can see a board that has a patient, and everybody is assigned a team role, and they can put equipment on, they can move medications around, and you can see how that patient evolves in real time. This is a little more complicated. This takes a little more time to figure out how this works, but is a little more realistic and a little more interactive. So it depends on what you're looking for. So this is my last slide, and this is just a list of resources if you're interested in finding out more or looking something up. This first resource I alluded to early on. This is the Nemours website, and they have a number of 1-hour free pediatric lectures. If you look at the lecture called COVID, a Year in Review, I believe it's called, the last half of that lecture is education on vaccine hesitancy that we talked about earlier. The second site is the data that we looked at the beginning of the lecture that's maintained by the AAP. The third site is the COCA webinar site from the CDC. This is the Clinical Outreach and Communication Activity webinar site. They have a number of adult and pediatric webinars on there. They address things like pregnancy and vaccines, breastfeeding and vaccines, pediatric COVID, and sort of what we learned over the past year as well. And then the last one is the link for the Center for Traumatic Stress. Obviously, both healthcare providers and children have been under a tremendous amount of stress. We have seen issues with mental health increase over the past year, and this is a great website in that most of the resources are quick. They're a 5-minute read, a 10-minute video. They go over sort of healthcare providers and mental health, things that you can do for self-care, resources for mental health. They also discuss how we should be discussing COVID with children, things that we can do to get them safely back to school, things that we can do to help with their stress and their mental health. This is the last slide. As always, if you guys have questions or wanted to hear more about this, please reach out to me. Be safe out there and take care.